Coffee with Coker is a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape.
Welcome back to another episode of Coffee with Coker. My name is Mark Reiboldt, and I'm the host of today's podcast. And we want to thank everybody for tuning in and listening. And we got another topic here that we're going to talk about that I think is relevant to all of our audience, and we get a lot of questions about. I like to always cover some of our housekeeping real quick. So again, thank you guys for listening. You can find all of our podcast episodes at coffeewithcoker.com. So if you like this podcast, I really want to encourage folks to go out and listen to the others. You can find them there at coffeewithcoker.com, as well as all of the content that Coker puts out. We put out thought leadership materials literally every week. So there's a lot of really good stuff there, not just related to this topic, but all the different things that Coker does and works with clients on. So I think that would be helpful for folks. And you can find all of that at cokergroup.com as well as coffeewithcoker.com. So also, if you want to follow us on social media, all of our information also goes out, particularly on LinkedIn. So I really encourage folks to follow Coker there because, again, that's a good way to stay up to speed with everything that we're putting out there. So with that, again, thank you guys for listening. And I want to jump into the conversation here. We actually have a new guest joining us on the podcast today, Jana Sizemore, who is a vice president in the area of the firm where we do a lot of physician compensation consulting. And that really entails a lot of different things, whether it's comp valuation or it's strategy around compensation modeling and different types of compensation plans for physicians. And so that ties into really what we're talking about today: clinical co-management agreements or co-management arrangements, whatever, there's kind of different terms in terms of how people use them. But this is something that we've been doing with our clients for years, literally. And it's something that it's one of those models or arrangements that may not be right for all scenarios, for all organizations, but it's something that I think has been very beneficial and very helpful for a lot of our clients, where the standard, if you will, alignment model or alignment models don't always work as well. And so this is just one other possible alternative for consideration. And there's some nuance to it. And that's what we wanted to talk about and why we wanted to cover this, because again, if it is a viable opportunity or a viable option for your organization, there's definitely some stuff that you're going to want to understand about how clinical co-management arrangements work and ultimately what's entailed. So Jana, thanks for joining us today. And I guess as we dive in, maybe just start with a very general introduction to co-management arrangements. What are we talking about? What does this even mean?
Sure. Thanks, Mark. Clinical co-management agreements are one way that a hospital or health system can further align with a physician group. So the tightest alignment, obviously, is direct employment, and sort of stepping outside of that realm, the next most closely aligned arrangement would be a professional services agreement. And a co-management is yet another tool that a health system might use in order to align with primarily surgical specialties. So if you take, for example, a service line that a hospital is trying to further develop or further bolster, they can partner with one or more independent physician groups to support that service line. So many times we'll see co-managements formed to help support service lines such as orthopedics, cardiology, urology, OB-GYN, along with many other service lines.
Yeah, I like the way you put it, because it's one of these other options. And I think, while this isn't always the case, when you are talking about surgical specialties and subspecialties, the traditional employment model or even the PSA model that you alluded to, it doesn't always make sense. For it could be for a variety of reasons, which we don't need to get into there. But sometimes this is that other alternative. And like I say on a lot of these podcasts where we're getting into something it can be fairly nuanced. There's obviously a lot here. We're going to talk about this topic for a few minutes when, we can literally spend hours and we do regularly spend hours with our clients, helping them to understand the ins and outs of the model as a whole. But obviously there's a lot of nuance there when you get into applying this type of arrangement to any specific scenario or group or organization. There's going to be a lot of variables there. So I say that as a little bit of a disclaimer, just to point out, we're not going to be able to get into all the weeds here. There is a lot that can go into this, but if we can just tee it up a little bit, I think, again, that may be helpful. And you talked about how this is fairly, a lot of times these are a good option for surgical specialties. What are some of the benefits or reasons why this may be relevant for them, or it may be a good alternative for them to at least explore?
Great question. One of the key hallmarks of a co-management arrangement is that it allows a physician group to maintain a certain degree of independence from the hospital. And a lot of surgical specialties, in particular, I think want to maintain some independence. And a co-management agreement provides opportunity for increased physician participation when the administration for the healthcare system is looking to improve and grow a certain service line. So the physicians can take part in making important decisions that might entail improvement to patient care and quality outcomes. This sort of arrangement does have some different components in it. They're usually set up to require physicians to help in developing the program to improve staff satisfaction along with patient satisfaction, because sometimes they are seen as the leaders of that service line. So you want to make sure that all of the clinical staff and administrative staff that help to support their service line are working very closely and working very well together. The clinical co-management provides quite a bit of management and oversight by the physicians. So I think this might be a good time to talk about how these are set up structurally, and then we can dive into some of the aspects and roles that the physicians might take on. So when we talk about physicians and hospitals entering into co-management arrangements, this is typically a several year arrangement in which the hospital service line management administrators will partner with a physician group to set up certain committees that oversee, and almost like medical director roles, to oversee programmatic development. So if you think about a traditional medical director role, this is something that when describing it to the physicians, they can very closely liken it to. So you can say that the co-management arrangement will have a component to that is, meeting driven, where we're meeting to collaborate and discuss about how to grow, how to improve a certain service line. And then there's also a dynamic of a co-management arrangement that you want to see improvements. And so there's a big portion of a co-management arrangement that's focused on those performance improvements. And so ultimately, at the end of the day, we're talking about, a financial arrangement that this is. And I'd like to kind of dive into just very briefly how that's structured.
Yeah, please.
That will drive what the physicians are doing and their participation in the co-management arrangement.
What I'm hearing is the arrangement is the entity, if you will, that the practice, the physician group comes into, the hospital comes into, there's committees, maybe directors, or there's a representation from both parties, both groups. And the hospital is ultimately paying those physicians for providing certain services as defined under the arrangement. Is that a pretty maybe oversimplified description?
Yeah, I was going to say that's a very high level description of this arrangement. And Sometimes the co-management arrangement will be structured such that they're formed a board where you have like a board oversight that has members of on that board on behalf of the hospital as well as the practice or practices. I do want to highlight that co-management arrangements don't necessarily have to be with one standalone group. They can be partnerships with multiple groups, depending on the size of the community.
So it could be fairly sizable. So I know there are some points we want to make about the compensation piece that comes from the hospital to the arrangement for services. But before you do that, maybe talk, if you can, about what are some of those typical services? What does some of that entail?
Right. That's a great point. So the physicians are typically responsible for a range of different administrative and oversight services. Some of those key services include participating in committee meetings with hospital representatives to discuss operations and planning. They also help to develop and implement different clinical protocols and oversee other quality and service initiatives. Those physicians are serving as, in a way, they're serving as medical directors so that they can coordinate with other service lines as appropriate. So, for example, if we're talking about a group of orthopedic surgeons to advance the orthopedic service line, they'll need to coordinate with others within the healthcare realm. So they're going to definitely need to coordinate with anesthesiologists.
Hmm.
The physicians also provide operational and financial oversight. So this could be anywhere from sitting on committees that help to develop uh, operating and capital budgets to providing input regarding the level of staffing that would be required and the procurement and utilization of certain supplies or surgical equipment that's needed if they're taking on, for example, advancing different robotics instruments, for example, in surgery or any unique surgical equipment. And then obviously, as they're the experts for their specialty, they will act in a supervisory role for the entire service line.
So that includes anybody, all the staff, administrators, support, all of that.
Correct. They would help to oversee the entire service line. And that's where I mentioned that it's akin to thinking of it as a medical director role.
Gotcha. Gotcha. Yeah. Yeah. There are a lot of similarities there for sure, because it is, again, a management agreement, management services that are being provided, which I guess kind of begs my next question. If I'm a hospital and I'm looking to align with, let's go back to the example of an orthopedic group to support and manage our orthopedic service line. What are some of the kind of expectations or some of the proposals I would be looking to pose to the actual physicians, the clinicians that are participating in the management process?
Great question. So the different requirements of the physicians participating in the co-management arrangement might be that they are a member of the hospital's medical staff as defined by the medical staff bylaws, that they be a very active participant in in the hospital service line. They will probably have a minimum hourly requirement to support the operations of the service line. And those usually come, a good example of that would be to serve on a specific committee, whether it be, procurement, quality, patient satisfaction, et cetera. They will obviously be required to abide by whatever policies are established within the co-management agreement, and they might be required. This is not necessarily typical of every co-management, but we do see occasionally that participation in call coverage is a requirement. And another aspect is that the participating physicians would be asked to refrain from participating in the management of any competing facilities service line.
Yeah, that makes sense. And I guess, that's going to vary depending on, the size, scale, and scope, I guess, of a lot of these are types of arrangements, but that seems like pretty straightforward expectations there. So I do want to come back now to talking a little bit about the compensation or the financial aspects of these arrangements. And I always, whenever we get into these types of discussions around comp and models and different arrangements, I always like to, again, point out that each one of these arrangements, each scenario obviously is going to be based on its own, different aspects, unique components and different merits. So there's not, I guess my point is, I don't want us to come across as like there's, one single way to break down the financial aspects of a given co-management arrangement. But there are probably, I imagine there are some kind of bigger picture, higher level perspectives, some baseline items that do play into how these fees for these arrangements, for these services are ultimately set, and obviously need to be within the confines of fair market value. So to the extent that you can, kind of give us a rundown on how the financial arrangements typically work in these types of models.
So the analogy that you made there to one size fits all definitely does not apply, because you want to tailor the co-management fees that are associated with the arrangement to the desired outcomes for the service line. So to back up and talk about the typical structure, there is usually a base or fixed component, and then an incentive or variable component to a co-management agreement. And the desired, outcome with I'm going to go back, speak of these backwards. So in the incentive component that is usually at risk, those metrics are typically based on quality, operational efficiency, satisfaction, whether that be employee or patient satisfaction, and further programmatic development. And then in the base or fixed component, those fees are going to be tied to such items as leadership, directorships, program development, day-to-day oversight, committee participation. And typically the base fee is structured so that it's based on a set number of annual hours. And the incentive or variable component is usually tied to predetermined performance metrics. And those predetermined performance metrics are sometimes based on what historically has been measured for such a service line.
Mm-hmm.
So, for example, readmits are very commonly seen. Patient satisfaction. You don't want to set the bar low when it comes to patient satisfaction. You want to see continual improvement in any of the metrics. So it's important to involve the physicians when initially setting up those metrics that they'll be measured against when it comes to calculating the incentive payment portion of the co-management arrangement.
Right. And so in terms of determining the split or the breakdown between the base and the incentive components, without, getting again into specific numbers or percentages, but is that negotiated in the arrangement itself? Is that something that varies and it changes based on different participants, different timeframes? Or is it kind of like, yes, we're setting this is what we're willing to do on the base side versus the incentive side, and you can kind of take it or leave it?
Right. So usually the percentage split between the base or fixed component and the incentive or variable component is set out at the inception of the arrangement. And the practice or practices and hospital, they need to work together to determine what that split will be. Very commonly, we see something around a 50-50 split, not to set that as the guideline, but we would recommend that a hospital and physician group of groups really focus on setting the incentive components, and to think about setting the incentive metrics takes a lot more time when trying to negotiate what fees are going to be tied to each component, whether it be the base or the incentive portion.
What are some of the other, I mean, what are some of the typical things that you've seen as far as the considerations when they're talking about if you're basing compensation on meeting certain metrics that qualify under those incentives, they have to be tracked and documented, obviously, so that you can actually determine did you meet them or not. But what are, I guess, any other considerations that may come up in these negotiations as far as exploring how those incentive metrics are based?
Good point. One of the actual items has to be how feasible is the metric. So, how transparent and is that measure? And has it been measured in the past? Do you have access to the data in order to support the metric, right? And we want to think of the different metrics to drive the desired outcome. So, one important aspect is to align the broader hospital system vision and goals with those performance metrics, and then narrow that down into the improvements that are desired for the individual service line. So, those considerations can range from a very broad view to thinking of current performance and what little achievements you want to see year over year to help drive an improved and growing service line.
Yeah, it makes sense. Kind of a sum of the parts, a number of different components all going into kind of a end goal or objective, I guess, is what that kind of comes out to being, which makes sense. And so, is there any, like, again, we don't want to say specific percentages in terms of how these fees are typically based, but are there any prescriptions or general recommendations or correlations there between, if it's of a certain size, then you're probably talking about a certain thing, or is it just very, each case is unique and stands on its own, and so there's no chart to graph, it's literally up and down depending on the individual case and organizations involved?
Good question. So, I would say that how the co-management fee is, ultimately set is going to be based on hospital management's um, decision, because they will be the ones paying the independent group or groups. Whenever we value a co-management arrangement, we tend to look at obviously the level of services that are provided, the different performance incentive metrics that are included or being contemplated as part of the arrangement. And then also to look at the size of what's being measured. And when we look at a service line, net service patient revenue is what we use to define size. So if we're talking about maybe a $30 million service line versus a $150 million service line, obviously those are two very different size and scope of services that are provided at the hospital and by the physician group.
Hmm.
And when it comes to setting the management fee, it's usually based on a certain dollar amount. And then when we're looking at it based on as a comparison to the net patient service line revenue, then we measure it as a percent of that. And what we typically see is a higher percent associated with smaller service lines and a smaller percent of revenue affiliated with a larger
Hmm.
service line, as measured by net patient service line revenue. So there's a bit of an inverse relationship there. And when we value those, we always want to take into consideration all of the services that are provided. So it's not just, how many hours are the physicians collectively contributing each year. It's what is driving the performance metrics and looking at how aggressive are they? Were certain metrics reached, or are they falling short in maybe, 9 out of 10 metrics? Then there will be, maybe a shortfall in any fee that's actually paid out in a given year.
Yeah, I think that's helpful context because your inverse relationship that you mentioned, it could be perceived as a little counterintuitive because one may assume that, the larger the service line in terms of net patient revenue, there would be more service, more management, more time, more metrics, all of that involved in something like that versus something that's smaller that, again, one might assume there's not as much management needing to go in those. But what I'm hearing is that inverse relationship suggests it's actually the opposite because maybe, sometimes the smaller service lines actually require that more time and attention to growth and maybe not as many personnel resources or again, whatever it may be. Is that kind of the thought there?
I was going to say, to maybe clarify a little bit from a whole dollar perspective, the larger the service line, there will be a larger potential management fee that may be paid out.
And the dollar amount.
Yeah, dollar amount. But when we talk about how we assess it as far as from a fair market value perspective, we look at it holistically as a percent of revenue.
Mm-hmm.
And so, yes, because of the risk versus reward principle from finance, or harkening back to that, if you have a smaller service line, it will take more resources or a higher percent of revenue compared to a service line that might be twice or three times the size. Will take, approximately the same number of administrative oversight hours, and that will represent a smaller percent of overall revenue.
Yeah, that makes sense. And again, I imagine there is probably a progression too, right? As they grow, as they add on more resources and thus generate ideally more revenue, that may shift some over time.
Right. And that's when we see going back to the performance metrics, when we see those set up initially. So if we think of a co-management arrangement that might have a 3-year initial term, the performance metrics that you see in year 1, year 2, and year 3 are intended to have different outcomes. And those 3 different outcome levels are intended to be representative of continual improvement. Now, we're not talking about, harnessing the moon, but what we want to do is have set reasonable goals that the physicians and the hospital can reach collectively.
Right.
And so what we want to do is see continual improvement, growth, and so forth, improve quality for patient outcomes.
Yeah. It makes sense that you would set different expectations and targets for year 3 versus year 1 and so on. So that makes sense.
Precisely.
Well, this has been very helpful. Again, I know, as I said earlier, we're covering this at a very relatively high level, general informational perspective, but there's a lot here. But I think at least sets the foundation, talking about co-management arrangements as a potential option for clients out there, and I think that's something that we're seeing more and more, which is again why we wanted to talk about it. But this is helpful, at least setting a foundation, and there is a lot we could get into here. And so I just wanted to let people know, if you have questions or like specific questions you want to get into as far as how something like this may be an option for your organization, whether you're on the physician group side or on the hospital side, looking to engage with particularly your surgical groups and surgical providers in the community. Jana and others on our team that cover these types of arrangements are always available to answer any of those types of questions. And if you want to look in any more detail about how something like this may be relevant for your organization, I definitely recommend reaching out to us, and we'll make sure Jana's contact information is available in the notes and any other information that may be relevant here. But I know we'll continue to talk about these because, again, the more questions we get, the more activity we do around these types of things. Again, they just I think they continue to grow with more interest. So, Jana, I appreciate you spending a few minutes talking about this. And like I always say, we'll look forward to continuing the conversation in future episodes.
Thanks, Mark.
Thank you.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us in a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.
The information presented and discussed in the Coffee with Coker podcast is intended strictly for informational purposes only. Listeners are solely responsible for employing their own research methods when weighing, valuing, and considering the information and recommendations provided by Coker. The content included in the Coffee with Coker podcast should not be treated as financial or investment advice. The information presented in this podcast is not legal advice, nor should you rely on the recommendations contained herein as a legal opinion. All information contained in this podcast is considered current as of the date of the recording of this material, but laws, regulations, and pay requirements are subject to change, and Coker has no responsibility to update this podcast to reflect any such changes after the date this podcast was recorded.